Good afternoon. Thank you all for joining us today. We will go ahead and get started while some people are still joining. It looks like we've got a handful of people who are here, and thank you so much for joining us. My name is Eden Barnhouse. I am the marketing manager at SlicedHealth, and I will be doing a little bit of an introduction today and then passing it off to Ken. So, welcome to Denial Proof, our webinar to discuss the pain points and denial trends of solutions that you can implement to make some immediate differences. We know that this is a highly relevant topic. This is something that a lot of people have messaged us about and been ready to talk about. So we're really thankful for your time today. As you will notice, your mics and cameras have been automatically muted for you when you entered the webinar, but please don't let that stop you from participating with Ken today. If you make your way to the chat, you will have the opportunity to ask questions and comments there. You can even ask us for the slides, or if you'd like to see this in direct correlation with you and your hospital team afterwards, you can let us know and we can set up some time to meet with you privately and make sure that you have all your questions answered as a result of today. So I will be monitoring the chat while Ken is presenting, and we're hoping to have some time at the end for Q&A, so feel free to drop as many questions there as you'd like, and we will try to get to as many of them as possible. And if for some reason we are not able to get to all the questions, then our team will personally reach out to you to make sure that those are answered after the fact. So luckily, it's time for me to turn things over to Ken. Ken is our Chief Client Officer at SlicedHealth, and with his background as a hospital CFO, he knows the questions you're dealing with in the denial world better than just about anyone. So he knows what keeps you up at night, not only from a vendor perspective, but also from the hospital C-suite seat. So this is something that he's seen both sides of, and he will be a very, very valuable resource to you. So I will mute myself and take myself off the screen so that Ken can take over the presentation. But again, I'll monitor that Q&A in the chat, and am looking forward to your questions and comments, and we'll get to those at the end. So Ken, take it away.
Awesome. Thank you, Eden. Hopefully I am not muted. I think that's true. I am really excited to be here today for a lot of different reasons. Number one, this is different than anything I've done before. If people have seen me present at other places doing other webinars, it tends to be very focused on what's going on out in the world with insurance companies. How are they taking advantage of us? And what are some of the things that we can do to kind of help get control of our relationships with those payers? And this is very different because in this case, I'm gonna be less reactive, I guess, to the insurance payers and move the focus more on us and what we can do to be more proactive instead of reactive to the denial situation that we're in the market and the things that are happening. So that is very different. It's a new presentation, which for me and for Eden is fraught with fun, excitement, and not really sure what's about to happen because this will be the first time I've done this. And anybody who's watched me present before knows that no presentation is the same, and I'm never really sure what I'm going to say as I go through it. So that's part of the excitement. The second thing that is going to be interesting today, I'll just let everyone know ahead of time. I am post-COVID, been out of the bed now for 3 days. This is my third day trying to live life after being in the bed for a week. So there is an opportunity that during the course of this, there's going to be some interruption because of a cough or something like that. I hope it's at a minimum. I have tried my best to prepare for this hour to try to keep that at a small amount, but I won't promise it's not going to happen. But All those things make this a little bit unique for me today in this webinar. Um, so let's see what Eden has decided I'm going to talk about. So let's look at the agenda real quick. One of the very first things I'm going to talk about is exactly what the issue is, because I want to make sure people understand. I think a lot of times we miss the I think we miss the magnitude of the problem we're struggling with the payers and the issue of missed payments and denial. So I want to address that real quick. The second thing is to talk about data. The reason why I want to talk about this is being able to get to a proactive state means you've got to know what's happening to you, be able to identify root causes and get there. So I want to talk a little bit about data and how it can help us get there. And then I want to talk about, while this is not all of the issues that we face in a denial world, these are the things that have been picked out specifically for this presentation to go through and discuss credentialing, those issues that may occur specifically around that, how we solve for them, charge master issues that create denials and underpayments, and how those can be attacked proactively. Same thing with documentation. That is probably the area in this particular conversation as a CFO that a former CFO that you can imagine I probably have the least expertise because I've never had to document medical care, but we'll take a stab at that. Registration, this is one of those things that as long as I've been in healthcare has been an issue, and hopefully I don't go too far off the rails with my own vent on what I think about registration and the way it should be put together. And then the last thing is timely filing, which I'll just go ahead and tell you, I see as kind of like an unforgivable sin when it comes to this ideal of a denial and ways that we can attack that. And then hopefully we'll have time for question and answers at the end. The first thing I want to talk about, though, is risk. This is really the opportunity to state the problem that we have. And risk, for me, is very much about our perception. And the reason why I want to talk about this, I think one of the best examples I can give a lot of people have heard, and that is we all believe that we all believe there is some level of risk of getting in the ocean and being attacked by a shark. And I think it's, for some people, it's a bigger fear than others. For me, it's a huge fear. I like the beach, but I don't like the ocean because there are things out there that will eat me. And it makes me assess that risk at a different level than, let's say, walking through a pasture. And some people have heard this analogy given, but I'm going to restate it. There are somewhere in the neighborhood 8 to 10 people that die from shark attacks every year, but yet you are 5 times more likely to be killed by livestock than you are a shark. And so the perception is, me in Tennessee, I am fine walking around anywhere and okay. And I'm deathly afraid of being in the ocean, but that is not the real risk, potentially. Same thing with stairs and elevators. Some of you may have heard this. Most of us will take an elevator. We won't think much about it, but we definitely don't think about it if we take the stairs. Something could happen in an elevator we have no control over. It gets stopped, it drops, something happens that causes injury. And it does happen. It happens somewhere around 11 to 18 times a year. Somebody has serious injury or a death in an elevator. But when we take the stairs thinking we're being healthy and we're in control and we don't have a problem, we don't think about that much. But over 1,100 people die or have serious injury on stairs. And so, again, I just come back to this theme. Knowing the risk is different than maybe what we perceive sometimes. So, I always say that anybody, for instance, that's on this webinar right now is a risk taker. You're a risk taker because you are in healthcare. You're a risk taker because you're in healthcare working in the rev cycle. And it has inherent risks that most people don't stop to really consider and understand what that risk is. So the risk that I'm going to propose to you is 36%. What this means to me is that in healthcare, anybody providing care, you are at a 36% risk of not being paid for the services you provide. So that can happen through denials. It can happen through underpayments, any of these types of things. So just think about running a business where a third of the time you know you're not going to get paid right. That's a big risk. And that's the world that we live in. In my other presentations, I go deep into this, but I don't want to go much deeper than this. I'm just trying to state the problem that, denial rates are being reported as high as 21% for commercial payers. And the underpayment percentages, some have this as high as 20%. I'm putting it on this slide at 15, which is how I add those up and get to 36. But it's a real issue. And we have to find ways to combat it on the appeal side and those types of things, which is what I'm usually talking about, which is very reactive. Today, I want to talk about being proactive so that if you're experiencing 36% in your facility, you can change that and get it to 10 or 12 and not deal with it at that level because you're keeping the denials from happening. You're keeping the underpayments from happening. So that's my goal for the day, is to kind of talk through those things that we can do to take a proactive approach. The first thing I want to talk about is data analytics. So data is one of the key factors, and what I have found in my experience running hospitals as a CFO and a COO, as well as doing consulting and doing the work that I do today with SlicedHealth, what I have found is that the majority of people really struggle to get great data around what denials are. And it sometimes people can tell me what their denial rates are. A lot of times people don't know that number. But what I'm talking about when I think about robust reporting is the ability to be able to analyze what's occurring in that rev cycle. I'm sending out claims. How often are they being denied? That's a number. But what's more important to me is to get to the what, where, who, and why, so that I can go back and change processes in the beginning so I can keep it from happening. It's one thing to know that to do the appeal. It's another to keep me from ever having to appeal a claim like that again. So in order to get there, the kind of data that I'm referring to is very similar to what we do at SlicedHealth and what we've built our platform around, which is business analytics that goes out, takes all of the information that's coming back from those remits, being able to put it in a format that is in a summarized form so that you can see your denial rate is 15%. You're writing off this much each month. Here's the trend in that. But more than that, to be able to quickly pivot the data and isolate it and say, it looks like CO16 is the number one CAS code, or CO197 for prior authorization is the number one CAS code. To be able to select it and immediately isolate it, see that trend, see those claims, see where that's happening, break that down literally in seconds to get down to who's the physician it's happening to the most, Who's the insurance company it's happening to the most? What is the combination that it's happening the most? Is there a service? Is there something going on? So I can get down to the root of more or less every time this happens, this happens. If anybody's ever seen me demo our product, you will have heard me say, the ability to go in and say, you know what, I think every time or Dr. Jackson does a colonoscopy on a Blue Cross patient on a Thursday, I have this problem. Well, the ability to quickly put those parameters in or pivot data to get to that um, can make all the difference in the world. And like I said, what I find is most people struggle even to get the high level summary information, much less dive deep into that. So it's one of the things I'm proud of what we do at Sliced Health. The other way to do that is then to be very claim specific about that information. Hey, this happened to you 100 times. Here are the 100 claims. Here's how that's organized by payer, by code, by physician, and be able to look at it claim by claim to get to root causes. The other point that I want to make about data, though, is data is only as good as what you do with it. It is, I'm just going to tell you, as a CFO, and before that, being in public accounting, data has always been my friend. I love it. I can't get enough of it. But just to put it out on a dashboard, to put it up in a report, to be able to view it, that's fun and it's cool and it's neat. But our COO, Mike McKenzie, I'm going to mess this up. I'm not going to say it exactly the way he says it, but data in the absence of action, it's just noise. It's fun to look at, but if you don't change anything about what you're doing based on the data you get, then why have the data? So there's two issues here. Make sure you have the right data. The second one is then use that data to drive action to improve the results. And so that really is my key points when it comes to the data. Make sure that you have access to it, and then once you have access to it, use it to its fullest extent to be proactive and make the changes once you find the root causes. Now, I'm going to go through some of these things one at a time, and we're going to start with credentialing. I'm not going to say I'm a credentialing expert by any stretch of the imagination, but on every one of these slides, as we begin talking about the area, whether it's credentialing, registration, documentation, whatever, I'm going to give you some of the claim adjustment reasons as well as some of the remark adjustment reasons, because it's not to be an exhaustive list, but it does give me an opportunity to talk about this. Number one, these things work in conjunction to get you to what's really going on the claim. But number two, you're going to find that these items, a lot of these items that you see on the screen right now, are going to repeat in each area. A CO16 is going to show up, I think, across the board. Some of these codes are being utilized by payers in different ways. Some of them are being used to identify multiple types of problems. And, this will be my moment to just pick on payers during this presentation. I do think that some of that is to confuse and make it more difficult for us to get to root causes sometimes, because Blue Cross will utilize CAS codes and remark codes differently than United will. The same problem will show up different in those environments. So you have to be aware of that. So that's really why I'm presenting these. Again, not an exhaustive list, but just to kind of give you that element of, hey, if you're seeing these on a regular basis, this could be the issue, but you're going to see a trend where some of these show up in every single instance. The common causes, for credentialing, the biggest issue, right, bringing on a new practitioner and going through all of that process to get them credentialed, right? There's a credentialing for the medical staff, there's a credentialing for the insurance company, there's getting all of that information accurately into the EMR, accurately cross-referenced the into the clearinghouse. And so there's multiple points of that need to be addressed. And so there are multiple points of failure. Um, Credentialing is one of those things I have to admit that when I was a CFO, I kind of took for granted. There's somebody over here, they're working on that. I don't have to worry about this. But that's true until all of a sudden you open a service and you start sending out claims and you can't get paid because that specific physician is not credentialed for that payer. Um, Now all of a sudden you're just stacking up AR and you're providing free service until you get that corrected and can begin processing those claims and getting that cash flow for the service that they're providing. Um, Taxonomy and MPI numbers, again, this is one of those things that I find more often than not are system problems. Either it's not set up correctly in the EMR, or it's not set up correctly in the clearinghouse, or it's not crosswalked correctly between the two, where I need a different code for a different service type or for the physician that's actually doing the work. So all of these things are issues that begin to create these problems. The other moment in time where this begins to raise its ugly head is when you change EMRs or when you change clearinghouses. Because remember, both of those are holding this information and it needs to be crosswalked accurately and completely if you're going to be able to send a claim and get it paid. So it is not uncommon for me to see somebody make a move from one EMR to another or from one clearinghouse to another, and they all of a sudden wind up in this cash flow crunch that they weren't anticipating. That has nothing to do with learning a new system. It has everything to do with just system build out and it being accurate because they're sending out claims that are never get paid because it has wrong information on it as far as taxonomy or MPI. So as a solution, these seem probably pretty clear based on the conversation we just had, but I can't say enough about how important that credentialing process is in the beginning when you're bringing on a new physician or when you have physicians and you have to maintain their certifications and licensure and all those things. Most of that is being done by somebody in the medical staff area, but it flows into what we're doing on the rev cycle side. And so there has to be great communication there. Two things, well, maybe, yeah, I think two things that are on here that I really want to talk about, the payer matrix, because what I'm referring to there um, is number one, you will always hear me talk about it's frustrating when an organization cannot lay their hands on their contracts. And so when I think about a contract payer matrix, that is part of what I'm thinking of. I want to make sure that if you have a contract, you have a copy. But the second thing is that under that contract, to be able to have a list, who are the physicians that are fully credentialed for that payer? It was some kind of acknowledgement if something may change in the future or is up for renewal in the future so that you can maintain it. Looking at that payer by payer is probably better than looking at it physician by physician from a rev cycle perspective, because you could have credentialing drop off at United, but they're still credentialed at Blue Cross. And so you want to track that payer by payer. Medical staff may not be doing that. So you need to be able to highlight that and track that and maintain that. The communication with payers, when I've talked about that in the past, I usually talk about, hey, anytime you have a relationship with someone, you have a better opportunity of fixing something when you have a problem. And I usually am talking that about systematic denials, or I'm talking about it from a standpoint of systematic underpayments. And now I got to work with a payer to get it right. But it's also true through this credentialing process. Just another element and point that makes it obvious that I have to maintain relationships with payers. If I have a rep, they ought to know me, my name, they ought to see my number and know it's me if I'm calling. Um, and to maintain that relationship both in good times and bad, um, so that it's a working relationship. The next thing is the charge master. This, quite frankly, I don't know that I have come across too many facilities that give this enough importance, um, just from a standpoint of action. We all know it's important. Everything we do clinically should, not all of it, but most of it routes to a charge that routes to the claim. And now, did we get all that right? So if I ordered this lab test, did it get on with the right rev code, with the right description, with the right CPT code, with the right modifiers, and am I billing appropriately for it? That's a lot going on in there, because it's not just the way that we bill for charging to get paid, but it's also compliance. And these things are changing on a regular basis. It is not uncommon for me to work with a hospital who has a charge master and they haven't reviewed it in 3 or 4 years. They've worked on it, meaning they've done things, right? They've added services, so they've added charge codes. They've deleted charge services, and hopefully they deleted charge codes. Um, but the actual compliance component of the charge master, the actual rechecking of my rates to make sure I'm being paid at as much as possible so that I'm not getting hit with lesser of language. Those kind of things, for whatever reason, seem to fall by the wayside. And people are doing it on an irregular basis. And that can lead to a ton of denials, because if there is something wrong in the charge master and it's on a service that's being performed regularly and it's in an outpatient area and those claims are going out the door on a automatic basis, well, you're just generating denials. And so those are the kind of things that I see that are happening the most in the organizations that are struggling in this area. It's just as simple as there hasn't been a review for compliance specifically in this arena. So, not surprisingly, I would ask you to look at it on at least an annual basis um, for compliance. But I think one of the interesting things here is, how do you set that up? We all know it's important, and I have been at facilities where we're all like, yeah, this is important, but we don't put anybody in charge of it. Maybe we have a group because my lab director is responsible for the lab charge master, and I'm going to let my radiology be responsible for the radiology charge master, and the ER director to be responsible for ED, and my clinic to be responsible for theirs. Well, that is probably not going to work, because you are now asking someone who got into that position because probably mainly their clinical backgrounds to now know compliance, not just, hey, what is the service I'm providing and do I have a charge code for it? And so there has to be some element inside the facility where all these charge codes that are being added are being reviewed for compliance as it's occurring. And then also the ability to systematically review for duplicate charges. I'm going to give you an example. The place I see it the most is in supplies. Um, some systems are really good from a standpoint that I set up a supply item, it has a charge code, it's routed into my materials management. And so it's constantly looking at the cost and it's just pushing the cost to each claim as it's being used. But not all systems work that way. And even systems that work that way, you can work around that. And so what I see a lot is think about your implants and something small like a screw, where I'm going to use a screw and I'm going to use it 20 times this year. I'm going to charge something different every time because my cost is going to be different every time. So is the system generating that and charging it to the claim at that moment? Or is somebody going in and saying, okay, I've got this thing, it was 15, it was, whatever, let's call it $150 last month, but now I'm using it this month. I've got a different cost on this item, and now it's $250 I need to charge. So I'm going to build a new charge code for the exact same item with all the exact same information, but now with a new charge. And before you know it, by the end of the year, what you wind up with in your charge master for this one piece of equipment or implant is you've got it in there 16, 20, 25 times, depending on how often you use it. And now, if I ever look at the charge master, what the heck am I supposed to use to charge for this thing in that moment? So I see things like that that occur on a regular basis. And that's why you need that center point of keeping track, being a traffic cop, if you will, the things that are being added and deleted in there to make sure it's accurate. Um, I think I always have, sorry for looking at my watch, but I'm trying to keep track of time. Um, from a documentation perspective, again, you see the codes. You'll notice we see CO16 again as an example. But this is one of those where I'm gonna talk about something specific on this list as opposed to going through the entire thing. I have never been in a situation in a hospital where I didn't hear from my medical staff, documentation has to be easier. Documentation has to be easier. I did not become a doctor to document. And so the systems and EMRs have begun to respond to that and try to make documenting easier. But one of the horrible things that came out of that was we get closer and closer and closer, and in some cases it's exact, the ability to just clone notes from one medical record to the other medical record, or to say, every time I see somebody, and I'm going to use a clinic environment in this point, but every time I see somebody in a clinic for strep throat, this, and this gets done, and I discuss this, and this every time. And so now I have a note, and so strep throat, bam, there it is. And now that is the same note that is on every single individual patient that ever comes in with that diagnosis. If that ever gets audited, it's not going to take long for someone to look at that and go, well, you're not giving individual care, and to question it. And we all know when we review a medical record, one of the things that I'm assuming it is still being said today, if it's not documented, it didn't happen. And so there is a risk as we make it easier and easier and we begin to use templates and we begin to create this thing where we can clone notes, where we cause the problem for ourselves. What happens in a lot of those cases, you will not get denials on those individually. What will happen is there'll be some kind of chart audit by the payer who comes in, finds that trend, then extrapolates it out and tries to take back hundreds of thousands of dollars instead of doing it on an individual claim. So for me in this area, that's probably my soapbox, is to make sure that documentation supports medical necessity and it is very specific to the patient that I am with. Care is individual. You may be doing the same types of things, but if Eden comes in with COVID and I come in with COVID, I am going to assume that I am older than Eden, that I have different comorbidities, that I have different issues that I am facing than her in a regular health situation. There are all kinds of reasons why those two charts should not look the same. And so uh, that is one of those things that we have to drive home. And I know that it's difficult because the medical staff doesn't like it. They don't like um, documentation. It is not why they're in the business of healthcare. They're there to help people. But it's going to be important if you're going to be paid right on this. I do want to talk about these internal audits because we do chart audits. I am going to tell you that those chart audit processes, remember, that's reactive. I'm getting data after the fact. Here's, 30 charts, 50 charts, however many you choose, and you go through and you review them. Does the documentation support the bill? Is everything there? Did we bill for anything we didn't do? Did we not bill for something we should have billed for? Is the coding correct? Is the diagnosis right? Right? We're checking all of these things. Those are data points. Back to my data analytics thing. When you get that, that stuff is only as good as what you do with it. So if you find the trend, you've got to go back and stop the trend. So it's fine to look at it. It's fine to report out, hey, we had 10% error. It was mainly because of this, that, or the other thing. It's this physician, it's this service, this is where it's falling apart. But you got to keep it from falling apart. If you don't take the data and go back and be proactive with it and change the process, then next time you do chart audit, same report. Because you're going to find the same errors. Registration. So this is, I'm just going to tell you, this is one of these moments where I think about my whole time in healthcare and I think about the rev cycle, and it still blows my mind that probably inside most of our revenue cycle departments, the least paid employee in that whole process is at that registration desk. But yet, they hold the power of getting a claim paid correctly or not correctly in a timely fashion because they are gathering all the information about the person who is being treated, the person who holds the insurance information around all of it. And if they get any of it wrong, there's a problem down the line. And so it has always irked me that we tend to put so much emphasis on our registration staff to get things right, but yet we're not hiring up to the skill level of people that we can reasonably expect to get those things right on a regular basis. So I'm probably not done on that soapbox, but we'll see when I get to the solution. You see some of the things that are occurring here. I'm not going to point them out specifically, except to go to the solutions and have a conversation about this. Staff training. One of the things that happens a lot when I think about a registration, there are two things going on in that moment. We're worried about patient satisfaction and we're worried about getting paid. And a lot of times those two elements are competing against one another because we think that patient satisfaction is specifically about, I walked into your ER, it took you 2 hours to see me. I walked into your ER and it took me 20 minutes to get back to a room. That's awesome. Well, that creates patient satisfaction in that moment. 90 days later, when you're talking to the patient because you got the wrong insurance information and you got the wrong demographic information in the moment you got them seen in 20 minutes, now do you think that they're happy or not happy? Satisfaction flows on both ends, and you've got, I know they compete against each other, but you can't let one overtake the other. And so I see a lot of people struggle with this. And in the fight to provide the immediate satisfaction, you create more dissatisfaction in your rev cycle process. So these are like the must-haves, right? Insurance verification, to have that automated as much as humanly possible. And I think today I'd be shocked if there's not a lot of people doing it automated because it's the norm. Um, Collecting accurate demographic information. This seems easy, but the truth of the matter is, if my whole goal is to make that process easy for you, have you moved? And you were here 3 months ago. Have you moved since then? Do you have the same insurance? Do you have this? And everybody's just going to say yes, yes, yes. Whatever gets them through the process the quickest. You run that risk asking questions like that as opposed to getting the real information and recording it. So I see that happen a lot in those processes. This opportunity to just say, oh, there's Ken Jackson. I know Ken Jackson. I trust Ken Jackson. He was here before. I'm just going to automatically register him based on what I have in the system right now. I don't really need to ask him any questions. Um, and now all of a sudden you've got wrong information because I changed jobs, because I have different insurance, because something has changed about it. So going through a process where I gather the information fresh every time is important. Um, and having these ways of making sure it's happening. I will say there needs to be some kind of audit on clean registrations and what those error rates are so you can give the feedback. Because without the feedback, you'll continue to churn the same information over and over and continue to have the same problem. So, and again, this is a place for pay for performance. You can either change your pay scale and hire to the skill level you need, or bring people in and incentivize them for great performance. I've done that in a lot of places, both in registration and in the business office, where we set KPIs, we track them, and certain performance created bonuses, created incentives. And I have been able in different offices to drop denial rates from um, in one place, it was 18. We moved the denial rate down to 6. Um, we were able to get registration errors at a decent level where it was only happening maybe 5% of the time, where we started with 15 to 20% issues. So don't overlook the power of incentives to create an opportunity here on the front end. This is the last slide I want to talk about. And this is the only thing I put on this slide because I don't know that I need to say anything else about it. I don't think there's a single person on the phone that when you see CO29 and somebody says, hey, we missed the filing limit on a claim, that your head doesn't want to explode. So my perspective here is this is one of those things that I've got to think 99% of the time can be avoided. A lot of times we hold claims, but in almost every case, I think the smallest I've seen in a contract is 60 days. I think the average is 90 for a commercial insurance payer. You have a year for Medicare from date of service fee to claim out the door. It's hard for me to imagine processes that can't get those done, but there are always exceptions to the rule. And so I'm holding a claim because I'm waiting for documentation. I'm waiting for a physician to sign off on something. I'm waiting for a lab specimen and I'm waiting on a specific result because I charge on result, not on order. All those things are things that can hold up a claim going out the door. But you've got to have something set up in the system that says these claims for this Blue Cross, I have to get them out in 90 days. These are 30 days old. These are 35 days old. These are 40. These are 50. These are 55. So that you can keep track of that, knowing you're coming up on that claim filing date. Because I would submit it is better to send a claim with an error on it than to not send it at all. Because the minute you get this code, you're done. You will, it is hard to overturn this. It is easier to overturn a documentation issue. It is easier to overturn um, some other item, billing item. Maybe there's a charge that's not on there. It is easier to go back and do a corrected claim than it is to overcome this. And so I put it here because I can't ignore it. If these things are happening to you on a regular basis, um, there needs to be a process around it so you know the claims that are coming up on that filing deadline so you can get them out the door and get them in the payment process. And I think we may have gotten to the end. So I just want to restate the whole point is it's one thing, and we do try to help people with this at SlicedHealth to create a mechanism where you can see what is happening to you. You can clearly see the work list of the things that have been denied to be able to organize that work and go do that appeal process. That's okay because it's going to happen and you're going to need that process. But what we've talked about this whole time is if I'm working on a 36% error and I'm doing all this work on the back end, isn't it going to be easier if that really is working on a 12% error? And so the whole point of this conversation and this particular these particular items has been around how do I reduce the rate of that appeal work and things on the back end. I saw Eden popped up, which means I'm probably at time, maybe even over. So
We are just over time, but Ken, that was really great. And I thank you all for participating with us today. This will certainly not be the only conversation we have on denial trends. So within the next day, we're aiming for the next 24 hours. We will have the recording to you all in your email inbox from our marketing team email address. So please be sure to keep an eye out for that in case it goes to spam or quarantine or anything. We will also make this live on our website and we will add the recording to our website so that you can come back and should you lose that email with the recording, we want to make sure you have access to this because this information, this makes a really big difference and we know that this is a pain point for you all and Ken, thank you for your time diving into a lot of these topics. So stay tuned. We will certainly cover this again in the coming months, especially going into Q4 and Q1 as you guys are working a lot to be proactive in a lot of your bookkeeping, your endeavors, your denial rates and things like that. So we know this is top of mind. Thank you all for staying a couple minutes over time and be sure to look out for our email after this. And should you have any questions that pop up, you can respond directly to those emails from us and we will keep a very close eye out for those. And we would love to meet with you and or your whole team and make sure we're answering the questions that that are top of mind for you all and applying what you learned today directly to what your office needs. So Ken, thank you so much and thank you all
yeah,
for joining today.